Hello and welcome to the MKM Healthcare Anaphylaxis e-learning training. This session will cover all the key areas of the 2008 anaphylaxis guidelines. You can go over this presentation as many times as you like to. You must complete the MCQ paper at the end of the session and you must score 70% or more in order to be issued with your certificate. The certificate will be valid for 12 months. First of all, let's think about the pathophysiology of anaphylaxis. Anaphylaxis occurs on exposure to a trigger or an antigen, and here are listed some of the most common antigens that have resulted in anaphylaxis. We do know that anaphylaxis is on the increase, as allergies in general is on the increase. After administering a vaccine, anaphylaxis is very rare, and it's estimated that out of every 1 million vaccinations administered, anaphylaxis would occur. The sort of things that are in vaccines that could cause anaphylaxis include antibiotics, egg protein, preservatives such as yeast or gelatin, thimerosal, which may be a byproduct of the manufacturing process, and formaldehyde. On the first exposure to a trigger, the body will go through a phase of sensitization, so it is unlikely on the first exposure to that antigen the individual would go through an anaphylaxis reaction. Anaphylaxis is a medical emergency and it needs to be dealt with quickly. However, this does not mean that the anaphylaxis would occur on the second exposure to the antigen. It may be the 10th, the 50th or the 60th. It can be whenever, so you need to be alert at all times. The 2008 guidelines have introduced a couple of things in order to help assist us with A. diagnosing and B. managing anaphylaxis. They have introduced an ABCDE approach, and this is to help us think about the symptoms that are involved with anaphylaxis. The second thing that they have introduced is the early administration of IM adrenaline. Once you've made your diagnosis that somebody is having an anaphylactic reaction, then you should administer the adrenaline intramuscularly into the deltoid as soon as you have made your diagnosis. Anaphylaxis is defined as a severe, life-threatening, generalized or systemic hypersensitivity reaction. The key difference between anaphylaxis and a severe reaction is the speed in which it progresses, and it's because of the speed in which it progresses that it is life-threatening. In the UK, there are approximately 20 deaths every year as a result of anaphylaxis. And this is underestimated because not always anaphylaxis will be reported. The reason that anaphylaxis is life-threatening is because of the systems that are involved. It can involve the airways and/or breathing and/or circulatory problems. It can also involve the skin, and it can also involve the GI tract. For individuals that are administering vaccines, the guidelines say that as a minimum you should be able to make your diagnosis of anaphylaxis using the ABCDE approach, and you should be able to get help as quickly as possible, because remember, this is a medical emergency, and then you should be able to administer the vaccine. Watch the video on the link on the slide in order to get more information on the ABCDE approach. These are some of the symptoms that can appear with ABCDE. The guidelines say you should use the following 3 criteria in order to make your diagnosis. Is there a trigger? Is their condition deteriorating, and is it life-threatening? And do they have a minimum of 1 symptom? If the answer to all 3 of these questions is yes, then this is sufficient to say this is an anaphylactic reaction and you should administer the adrenaline. The adrenaline should be administered into the deltoid. The dosage that we give is as follows. Anybody over the age of 12 should be given 500 micrograms, which is 0.5 mils. Anybody between the ages of 6 up to 12 should be given 300 micrograms, which is 0.3 mils. And anybody under the age of 6 but over 6 months should be given 0.15 mils, which is 150 micrograms. As soon as you have administered the adrenaline, you should see an improvement, as it would reverse all of the symptoms that have appeared. If there is no improvement in 5 minutes, then you should administer a second dose. If there's no improvement after 5 minutes again, administer a third dose, and you would continue to do so until there was an improvement. If the patient stops breathing, then you cannot administer IM adrenaline. It must be given IV, and this can only be administered by a trained individual. If the patient stops breathing, put them onto their back and start your CPR. It's important to know how to administer the adrenaline. If you have EpiPens or Anapens as part of your emergency equipment, you can watch the 2 videos on the slide, and this demonstrates how to use these 2 devices. These devices are recommended for self-administration, but some areas may include some as their emergency equipment for times when there is no clinician on site. The main thing to remember with the EpiPens is that they have a very short shelf life, so you must remember to check the expiry date on your EpiPen on a regular basis. All emergency equipment, including adrenaline and EpiPens, should be checked once a month. If you're a clinician, you would administer using a blue needle and a 1 ml syringe. It's important to keep the patient as comfortable as possible. If they're having trouble breathing, maintain their airways and their breathing as much as you can. If they're feeling faint, try to lie them flat. If they become unconscious but they are still breathing, place them into the recovery position and keep monitoring them every 5 minutes. If it's a lady and they are pregnant, remember to place them on their left side. The guidelines recommend that if possible, you should try to remove the trigger. If possible, remove the trigger if it is from a bee sting or a wasp. If it's from a drug, try to stop any further medication being administered. If it's from food, do not encourage them to vomit. Remember, if they stop breathing, start your CPR immediately. Emergency equipment should include adrenaline, which would be your first choice and your first treatment. Secondary line treatments would include oxygen, and you can give this at between 10 to 16 litres per minute or above. If you have fluids, it's recommended that you put fluids up as soon as possible. You can give second line treatments such as hydrocortisone, you can give Ventolin, you can give Piriton. At the end of this presentation, you will see there is an algorithm attached which has been developed by the Resus Council, and you should use this to follow the treatment. Also remember, in an emergency situation it's quite often difficult to remember the doses. On your emergency kits, make sure that you have clearly marked the dosages that should be given to each age group for your adrenaline. Remember to check this equipment once a month, and you will be checking that they are still in date and that the ampules are as they should be. So if it's recommended that it's a clear solution, make sure that this is the case. And you should have a minimum of 3 ampules of adrenaline. Post anaphylaxis, everybody must go to hospital, and they must go to hospital via blue light. Even if they are known to have anaphylaxis and they carry an EpiPen and they have administered their EpiPen and they feel better, there is always a risk that an individual could have a second anaphylactic reaction, and for this reason they would go to hospital. They would be observed for a minimum of 6 to 8 hours at hospital. Because as dangerous as anaphylaxis is, it is very short in the majority of cases. So the IgE levels will peak at about 1 to 2 hours post exposure to the trigger. And within 6 to 8 hours, quite often the body will be back to normal. In some cases, individuals can have a biphasic reaction where they have a secondary reaction, and these individuals would be observed for longer, usually 24 hours. The guidelines also recommend that the individual should have blood tests done to confirm the diagnosis of anaphylaxis. Once a diagnosis has been made, the individual would be referred to an allergy specialist who would go through all the education of recognising the symptoms of anaphylaxis, how to administer their adrenaline. They would also prescribe the first pens. If the anaphylaxis was due to a food, they would be referred to a dietitian who would go through in depth the details of how to read labels and how to look for foods that might contain elements of the antigen that they have an anaphylactic reaction to.